Yes, that's awesome. So let's go. We are here with Dr. Casavantes. We're going to ask him some questions about phalloplasty non-surgical, especially for our audience in phalloboards.info. We hope you enjoy it. Please leave a comment if you have any questions for further questions for Dr. Casavantes, Dr. Palmira, and Ian. So, hi, Dr. Casavantes.
Hi.
How's retirement going?
Retirement's great. It's a long journey. It needs a lot of work behind it, but it's really enjoyable. Thank you.
Are you retired fully, or are you back to the game?
Well, I am retired from seeing patients because since we care about patients, there's a time when you shouldn't see them, and my time arrived. But I'm still pretty active. I'm still working on the news, on the information that is available every day, and I'm in constant support for Dr. Morales and Ian and our patients.
I see you very active on phalloboards. You're still saying hello to patients and answering their questions. What is the most common questions you see on people on phalloboards?
Well, they have all sorts of questions. I mean, phalloboards is a very dynamic site. Probably, to the extent of my knowledge, one of the most active sites on the internet. So patients you get from the really knowledgeable that I go like, oh my God, what is this? I need to go and search what they're talking about, to the one that wants basic information, right? So I'm happy to help both. The one that doesn't know anything, especially the one that doesn't know anything, to the one that knows it all. So we're here to help everybody.
What interesting things you see for the next year on 2024 about procedures about male enhancement? Do you see, besides the penis, what else do you see that this technology is going further on, maybe the butt or the face or some other part of the body that we haven't think about? What procedures do you see besides penis?
Well, when I started doing fillers back in, I think, mid-90s, the indications were the glabella and the crossfit. And then from there we went to the whole face, and then we went to muscles, and we went to butt enhancement, Brazilian butt lift, to everywhere in the body. Probably phalloplasty was one of the last indications that we have. So we ran out of parts of the body to keep doing. So basically we cover it all, from the nose to the penis.
And for example, a guy that's getting phalloplasty non-surgical, what age are they really right now? Do you see the most? Are they the guys in their 20s, the guys in their 30s, 40s, 50s?
The bulk of our patients are in their 30s and 40s. However, legally, we can take patients at 18. Right. Mm-hmm. However, I really strong advise guys in their teenagers to wait, because body transformation, body modification is very important, especially when it's made with permanent fillers.
Why is that?
Because later in life they can regret. So what I recommend to teenagers or very young patients is to go for something that is absorbable and that eventually is going to go in the patient. If he has regrets or something, he can go back to basics. However, when we use permanent fillers, they are there to stay.
If somebody puts permanent filler on their body, how do they take it off? Or is it really difficult? It's not like just a common, you put a needle and they reabsorb the product. It's not like that?
No, we have three different fillers. Temporary, semi-permanent or long-lasting, and permanent. The temporary fillers is basically hyaluronic acid, HA, and that is dissolvable, which means you put an injection of an enzyme and it turns the hyaluronic acid into water, and then the body absorbs it. The long-lasting fillers are made of a microsphere that degrades with time. So eventually it'll disappear on its own. The permanent fillers are non-absorbable, non-biodegradable, and they are there to stay for life.
If, for example, I've had hyaluronic acid on nose one time I tried it, but it dissolved really quickly. It was like I paid a decent amount of dollars for it, and I like the results, but it didn't last. So I had to pay again this much amount of $1,000, $800 that they charge me each 6 months, which just seems ridiculous. It's not dangerous, right, to put hyaluronic acid, but it's very frustrating to have it. So I don't want the permanent. Is there a hyaluronic acid that has a bigger endurance than 6 months?
Yeah, I mean, there are a number of different hyaluronic acids, and every manufacturer claims that he got the longer lasting HA. In reality, in the clinic, which is what is important, what we see is that hyaluronic acid typically goes away very fast. So it's not cost effective, although it is the safer one, the safest one, because hyaluronic acid is part of our skin structure. So you're injecting something that is totally compatible with your own tissues. Number one. Number two, you can dissolve it if you don't want it. But the price for the duration of the effect is not good. It's not cost effective. At this moment, at this point, 2023, the end of 2023, I think that the semi-permanent filler is the response to phalloplasty.
I was hearing about Dr. Palmira and you talking about the secret of hyaluronic acid. You use hyaluronic acid, which is Voluma.
Yeah.
But what many people don't know is that its time period is very little. So, and a lot of people don't know the secret that there's a bigger advantage than hyaluronic acid, which is the one that you're talking about. What is it? Hyaluronic acid but boosted with steroids, metaphorically speaking, or what is this thing that can be better than hyaluronic acid that people don't know? Because a lot of people don't know that there's a bigger option than hyaluronic acid.
Right. Basically, when we started phalloplasty, 2007, we were the pioneers of this thing. When we started phalloplasty, we had two options, which was hyaluronic acid that will last probably a few months, and the permanent thing, linear PMMA. Years later, we had Elance, which is something in between those two. So Elance is non-permanent, like hyaluronic acid, and is absorbable, unlike PMMA. So in the mid, we have the Elance, which has the advantage of lasting a long time, but eventually, as you age, it will go away, and in the end, when you're in your 60s, depending on when you first injected, but in the end, you end up with your normal tissues, which sometimes is an advantage. If you have a permanent product, and eventually in your 60s, you need to start going to the urologist and this and that, they're going to be a little weird about your implant in the penis. On the other hand, hyaluronic acid you don't even have time to age when it's gone, right? So Elance, which formula is polycaprolactone, PCL, Elance lasts for many years. Well, you enjoy it, and then when you don't need it, it goes away.
Or you can just put again back the Elance on other doses.
Or you can retouch. Yeah.
Because what is the thing? Is the thing that patients or future patients don't understand is that the permanent is great, but after you age, after 60, you'll have to go to a urologist and you have to take care of your body, and you're putting yourself on a spot where a urologist or doctor will not want to work with you with your health, because you have that permanent thing, and it's going to basically just bother the doctor, and you can suffer risk for it. So is it just healthier to do the advance, enjoy your youth each period, and then on 60s it will just
get rid of it? To some extent, I mean, we have seen after 2007, after 15 years of the first patients of PMMA, they're good. I mean, PMMA will be with you until you age, until you die, basically, but it's not dangerous or anything. However, certain urologists will go like, I don't know what that is, I don't want to see you, things like that. But that doesn't necessarily mean that is a risk for the patients. It's just something that is better not to have when you're an old person.
What about for patients, because your clinic is in Tijuana, you've been here for how many years you've been here?
Well, as Casavantes Derma for many years, 40 years or something like that. Bioplasty, our bioplasty division started in 2007, September 2007.
What is your history with phalloplasty? I remember once talking with you, you mentioned Brazil. So what's the history? Are you from Brazil? Did you study in Brazil? What's the history?
Yeah, by accident, I started working on patients with facial lipoatrophy, secondary to HIV infection. So with hyaluronic acid. So the patients were very happy because we were able to reconstruct their face. But again, the results will go away in a few months. So we needed to look for something something longer lasting than DHA. So I started looking here and there and everywhere, South Korea, Europe, and somebody told me, hey, Brazil is working with something really cool. So I went to Brazil and I met Dr. Nakul, who is the father of this thing called bioplasty. And he taught me how to use this permanent filler. And we went through everything, to nose, to cheeks, the facial enhancement, facial reconstruction, gluteal augmentation, and everything. And one of the things that we covered when I was in my training in Brazil was phalloplasty. But I never saw him doing it anywhere. He just had a book and he had the theory of this. So I came back to Tijuana, continued working with HIV patients, and one day one of them told me, hey, can you enhance my penis? And I said, well, if you want, but I need to tell you, I need to disclose. You are the first patient. And I mean, you need to know. I know how to do it, but you will be my first patient.
And this is what year?
This is 2007.
Okay, 2007, okay.
Yeah. So he said, yes, go ahead. And we did it, and turned out to be, even to my surprise, to be very nice. So the patient liked it, and he told somebody, and somebody told somebody, and all of a sudden, by the end of 2007, my flux of patients turned into mostly penises. And at the time, the new medications for HIV were not creating the facial lipoatrophy. So the HIV patients were fading away, but then I got reloaded with phalloplasty patients.
And after that, you were just doing hyaluronic acid first at 2007?
Actually, we started with PMMA.
You started with PMMA from the start? Your first patient was with PMMA?
Because it was my first request. And then we started offering hyaluronic acid, but patients definitely went for PMMA. So I can tell you, in the beginning, I was doing probably 97% PMMA and just 3% HA.
And when did that skyrocket? Because you were one of the first or the only one that gave this procedure about phalloplasty.
Right. So it went away like foam. It was incredible. All of a sudden, somebody found us through a forum, and I was like, "What is this? What is it? What are you talking about?" And he says, "Well, you're famous in this forum. I was like, what forum? What does it mean? I didn't even know what it was. And it turned out to be follow boards. And then I started meeting coordinators and moderators from follow boards. They turned out to be, many of them turned out to be my patients. And it's been a great adventure.
Around how many patients have you heard?
I published a study in
15, I believe. 15, I believe it was 15.
With 700 something patients, but those were extracted from almost double because we were not trying to make any clinical trial or anything. So we were not keeping the records needed to make a clinical trial, just the records for the patient file. So we had to remove many patients. And then we need to remove other patients that were not authorizing their pictures and things like that. So from removing probably 2,000 patients, I still published a study with 700 something patients. So at the moment, I think easily we have seen 5,000 patients, which means that we have done 10,000 procedures probably. Because some patients are
10,000 hours.
Probably.
Well, yeah. 10,000. When you see patients, what are the different types of patients that you see? Is it more like in their physical type? That, okay, this one has a big penis, this one has a semi-different penis, long, small. Or is it that? How you distinguish them in category? Or is it more, this has circumcision, this one doesn't? What's the borderlines of each category that you...
Yeah, we have some guidelines, auto evaluation in our e-brochure that is available for whoever asks for it. And we have a section where the patient evaluates himself. And what is very problematic for us, number one, is multi-treated patients. Like at this moment, I have a patient that went through multiple procedures. He came to us first, we did several procedures until we told him no more. Then he found somebody else, and somebody else put a lot of cc's in one session. They removed it the next day because the patient panicked, and then they cut the ligament, and then he went to the US and got it extracted, and then after the extraction they had to put a skin graft, and after the skin graft he finally healed, and now he wants more. Of course, a patient like that we will not take. Another patient that is very problematic is a patient with micropenis. Micropenis is a penis that is no longer than 3 inches in full erection. And then...
and why is that? Why is the micropenis?
Micropenis is just a very small penis, no more than 3 inches.
No, but why? Why is it that?
Oh, it's a malformation. It's a birth defect.
But what happens if you put PMMA or
there's no room. I mean, we cannot. The penis has a normal penis is typically a little longer than it is in circumference. The typical penis, there are many studies, and it changes from country to country, from race to race.
Right.
But let's say a 5.5 inch penis in erection is around 5 inches in circumference. The moment you start augmenting the circumference beyond the length of the penis, then we start modifying it, and it is not so. So obviously, if somebody comes with a 6 inch penis, we have a lot of room to play.
Okay, yeah.
Right? But we have another patient that has 3 inches. We can only do a little bit before we turn it into a deformity.
Right, he's gonna have more product than penis, right? And what is that? Oh, okay, maybe even like it's so long, but the penis is down there, right? Exactly. I can imagine that.
That's what patients call the pig in the blanket.
What can a guy with a micropenis then do if he's your friend maybe or family member or just somebody that you okay, you cannot help him with your hands, but what can you say to those people that are watching, and if they have a micro penis and they want to improve their body, what can they do? I mean, that's something that's not risky, or maybe it's gonna be risk, but how do you find?
Yeah, that's something way more complex. We're not urologists, but those patients, first of all, they need hormonal treatment. I mean, I'm just talking here. We don't do this, but when they're in their infancy, they need some hormonal treatments or things like that. From the point of view of non-surgical phalloplasty, there's basically nothing that we can do.
Yes.
Yeah, and it's better to leave them alone, because I don't know if the urologist will do ligament cut or things like that, but from my point of view, it's better to leave them alone. No,
so basically, your advice is go see, don't do this, but go to the urologist, and the urologist can.
Yeah.
Okay, those are the steps then to do. Or is there? What about things that? What are myths or gossip or things that false information that go around that people, so-called experts, say this is going to increase your penis or make it wider or bigger? What are the things that you can say to people right now watching? Stop. This is not true. Don't waste your money on this. This is false information. What are those things that sound in your head?
Yeah, historically, the human being, the male has done everything to increase the size of his penis, from hanging stones to letting a snake bite your penis and it gets inflamed and gets bigger. I mean, we have done this since the human being, since the centuries and myriads ago. So it is so intense. It is so intense that a lot of people profit from that desire, from that insatiable will to make your penis bigger. So of course, there are all kinds of offers, all kinds of dreams that they try to sell. As a matter of fact, here we can talk about what is the small penis syndrome, which is when the patient thinks that his penis is small. There's nothing wrong with it, but the patient see the penis like being very small. And those patients will do anything. But guess what? The only thing that works is not the shrink. It's not that they go to the shrink and say, hey, my penis is small, and they have 10 sessions and they come out convinced that they have a bigger penis. In those patients, what works is fillers. Because they come in the room, they get the penis enlarged, and they go super happy. And unfortunately, the small penis syndrome is way more common than we think. We all have some degree of small penis syndrome, because we all want the bigger.
Would you say that the patient that you mentioned earlier, the one that you didn't want to treat no more because he already had enough and he went to another doctor, would you say that he has penis in that's an example of it? That's one type of person that would have that?
Yeah, that combined with, there's another condition, that is the dysmorphic syndrome. Are patients that are obsessed with fixing their face when the face has nothing wrong, making the penis bigger when the penis has nothing wrong. They don't even consider what their partner wants, right? Sometimes they want the penis to be bigger when the sexual partner goes like, I don't need it, I don't want it. But it is what it is. But yeah, there's a lot of, one of the biggest referrals of patients for phalloplasty is psychological conditions. Small penis syndrome, simply the feel to feel more manly, more endowed, and things like that. But there's always a psychological thing behind.
Would you say that there are patients that they have their girlfriends or their wife, and they tell them, hey, this is enough. I'm already good. I'm really enjoying it. Even though they hear that from the partner, they still want more. Those people exist. Those patients exist.
Yeah, there's a documentary. It happened a few years ago. It's called Big Like Me.
Big by me.
Big Like Me.
Big like me.
Like me, and the guy starts talking with the wife, and the wife says, "I don't see anything wrong with your penis. Your penis is normal." And the guy says, "Normal? That's exactly what I don't want to be normal." Right? Because everybody wants to be. Most of us would like to be the biggest one.
And why is that? Is it more psychological or is it biological? A fear of my body needs to feel big because I need to push things or carry things, survive? Or is it just psychological, cultural of the 21st century?
It's cultural. The vast majority of patients are just want to be bigger, to feel better, to feel the speedos, to look more manly at the beach, the gym. There's another thing that is called the locker room syndrome, which is a lot of patients don't want to show their genitals in the locker room, in the gym. And once they do the treatment, the phalloplastic treatment, they go happy and show everybody everything. So it's a combination of factors. And as I told you, many of the patients just want I just want it bigger. That's it. I will feel better. It's a psychological or how to say physically they will feel better. It's a person actually affect the personality of positively the personality of patients.
You practice medicine in the country of Mexico. Would you consider Mexican men to be obsessed with their penis and their size, or because you are a world destination where a lot of countries come to you for help? How do they compare? For example, are the Germans Mexicans don't care really about their penis compared to the Germans? Or what country have you find that have the biggest fixation on their penis versus Mexicans? How do they see their penis?
Interesting enough, even though we are in Mexico, we have very few patients from Mexico in comparison with other countries.
Right.
Like we have our number one country is the US, then Canada, and then Australia, and then the UK and Europe in general. But one thing that is decisive here is the practice of circumcision. The US, basically everybody in the US, every guy in the US is circumcised. Almost everyone. Whereas in Europe, almost everyone is uncircumcised.
Oh.
Right? And the fact of the patient being uncircumcised creates a lot of restrictions for us. For us, it's much better or much easier to work on a circumcised individual than an uncut individual. Because there are a number of factors that we need to take care of with the foreskin and the dynamics of the penis and everything. The skin in the circumcised patient is very firm, the implant is very stable, whereas in the other, the skin is totally movable and the implant goes all over the place. It can create the accordion effect. The accordion effect is when the skin with the filler bunches up at the base when the skin is pulled. So personally, I like to work better. I like to work on uncut individuals. Cut individuals. But we also work with the uncircumcised. But we tell them we need to be very light. We need to use little product if you want to preserve the integrity of your penis. And also irregularities are way more common in them. So basically, in Mexico is like Europe. Mexico, most of us, or most of the Mexican males are uncircumcised. So probably because of our approach is very light for uncircumcised individuals, probably that's the reason why we have other countries like being way more popular in the office.
So, for example, the United States is almost number one with circumcised patients and people in general.
Right.
So, what about Canada and Australia? Are those also two countries that have the same culture in hospitals about having circumcision on the birth? Or
I think it's a little more half and half. I think it's a little less because in the US it's almost certain that the patient's going to be circumcised. In Canada, Australia is give or take, and Europe is almost all uncircumcised.
What are the healthy benefits of being circumcised, and maybe negative traits of being circumcised? Just as you as a doctor, what's the vision of circumcision?
Well, it's not only medicine; it's also religion. Religion plays a big role on being circumcised or not. There are cultures that want circumcised patients. I mean, their kids. There are other cultures like the United States where they promote circumcision on everybody. Well, there are studies that have shown that the cancer in women is more common in those that are those cultures where the man is uncircumcised. But I think that practice is going to change over time. More and more patients, like from the United States, more and more patients are like letting their kids decide if later in their life they want the circumcision or not. It's a trend that goes like, I'm not going to impose a circumcision in my kid. I'm going to let him decide, right? Because there's a lot of controversy about it.
For the religion aspect, or also?
No, these are practical and personal aspects, right? There are patients that want to reconstruct their foreskin, which is, I mean, is possible, but it's not.
They want to reconstruct their what? Their
reconstruct their foreskin.
The skin. Oh, yeah. The skin. That was.
To put
why?
Because they want to have foreskin.
Oh, but does it protect them from the?
They claim, and personally, I don't believe that makes much difference. But they claim that the sensation is different in the circumcised individual. Because in the uncircumcised, the foreskin is protecting the glands.
Right.
And so it preserves sensation and all that. But it's questionable. I've asked a lot of patients and especially those that grew up without circumcision, and then they did circumcision later in life, and most of them will tell you, I don't see any difference. Basically, yeah.
So people without uncircumcised, do they suffer more from how's it called when they're with their partner and they it's premature ejaculation, I believe? Do they suffer more from that because they have more? Or is it just a myth?
Not sure.
There's nothing.
No, I'm not sure about that. Premature ejaculation, I think it happens in. I haven't actually read about it too much, well enough to.
The sensitivity. Do you have any? Maybe your patients. What can you say about premature ejaculation? Because a lot of the people that are interested in the subject maybe suffer them, or they want to last longer in bed. It's on the issue. So what can you? Do you have any recommendations for them?
Yeah, there's a study in. They are South Korean authors. I met some of them, and they made a study in patients with premature ejaculation, where they use fillers for the glands, for the head of the penis, and they claim that they take care of premature ejaculation. That's the extent of my knowledge. I don't know if it works or not. They published it, and seems to be that it helps with premature ejaculation, but I'm not sure. I haven't.
Is it mental? Is it a mental thing, or is it actually a physiological thing that hey, you have more sensitivity?
Both.
Is it both?
Yeah.
And what do they inject, the South Koreans? Is it HA or something, Botox or something like?
For the glands, it's always HA. No, I want to go back to the fillers. We have the 3 fillers that we use. One is HA, which is a gel that absorbs water, and the other 2 are microspheres, the solid microspheres. And those 2 that are PMMA and the lens, those 2 are very, very rough, very hard for the glands. So the only thing that we use for the glands is HA. And again, the same thing. It will absorb quickly and all that. But I do not recommend any of the long-term or permanent fillers for the glands.
Oh yeah, why is that? What's the problem about being so? Is it hard on the?
Yeah, it's hard, and you know the glands. The glands is a very special structure. The glands is the cavernosum body, which is like a sponge that gets filled with blood when the erection happens, and then there's a thin membrane covering it. So when you put a filler that is heavy, that it pushes the tissues, it can create lack of circulation, and it can create necrosis, which is death of the tissue in the areas. So these guys that have used those fillers that are very strong end up with scars and deformities in the glands, and it doesn't happen with HA because it's softer.
What are microspheres? What is a microsphere?
We have 2 fillers with microspheres. One is PMMA, which is the longest and most well-known product. The microspheres are made of PMMA, polymethyl methacrylate, which is like plexiglass. But these spheres are soft and are around 45 microns in diameter. They are bioengineered to just create a response from the body to make collagen around them, and without creating a reaction of foreign body. It's a bioengineering thing. And those are permanent because there's no enzyme in the body that will destroy them. The other ones in the lens is the microspheres too, but it's a polymer chain it's like a chain made into a sphere, and the body enzymes and the body metabolism start chewing the tips of the chain, and little by little it's the chain, but it's through years. So those are the 2 microspheres, different microspheres that we have. HA is not a microsphere. HA is a gel that absorbs water, and but the body absorbs
the enzymes destroy.
It destroys the HA or recirculates the HA at a faster rate than the microspheres, and that's the reason why the HA is. So
microspheres are a biological technology that once you introduce it to the body, it participates with the body. Then, right?
Correct. What happens when we have a foreign body inside our body? Let's say a bacteria or any foreign body, a thorn or something. The body comes and tries to isolate it from the body. First, it tries to eat it. So the macrophage, that are cells that eat things that we don't want inside our body, the macrophage comes, but the microsphere is bigger than the macrophage. So macrophage comes and he says, oops, I cannot eat this thing. So then the fibroblasts come, and the fibroblasts produce collagen. So they go like, okay, we cannot eat this thing away, so I'm going to cover it, so the immune system doesn't see it. So once they cover it, it's collagen that covers it, so that increases the volume. Mm-hmm. So that in the trillions of microspheres that we inject eventually create the volume augmentation.
Is there more technology yet to be developed on these products of PMMA launch, or right now we're at the frontier?
We're at the frontier. Yeah, of course, there are clinical trials and new products development and everything all over the place, but we need to be very careful when a new product appears in the market. We don't, of course, the manufacturer is going to tell you this is the best thing that has happened and it is very safe and everything, but you need to be very careful because, like in my case, that I've been in this solo, I have hit the wall a couple of times with new products that appear in the market like the best thing, the safest thing, and it turned out they're not. The 3 products that we offer at the time are proven and are long-term. There's long-term experience with everything. If tomorrow some rep comes and brings me something that is the newest thing, I will like, let me see. Let me watch it for a couple of years and then I'll decide, right? Mm-hmm. So yeah, and of course something is going on. At this moment, I don't know of any new thing that is revolutionary, because like HA, every time I get a rep, almost every time I get a rep in the office, he comes up with a new brand or a new variation of HA. The market is inundated with HA, but it's the same thing at the end. It's HA.
Mm-hmm.
Right.
Your clinic is Avanti Derma. We're actually here a couple of floors next. The next floor is Avanti Derma. We're here really close. And Avanti Derma, your protege or your student, it was being Dr. Palmira. Dr. Palmira basically is applying all of your techniques, and you're still participating with her on communications. You visit her and you help her with patients. What can you tell us about Dr. Palmira? How did you prepare her to be just like you?
Yeah, when I was working full-time in HIV patients, we hired this young doctor. I'm talking about, she knows better, but I think it was 2003, 2004. And she was an early graduate, and he started working with little things, helping me in little procedures. And as time went by, she got more and more experience. She started doing more and more. In 2007, she stayed in the practice that I was, but I quit, and I came to open this branch of Avanti Derma. And eventually, one day we spoke, and she decided to join me. This was probably 2012 or something like that. And we worked together for probably since 2012 to 2020, something like that, together with every patient. And sometimes she was doing, sometimes I was doing. But it was 8 years of training. And finally, I retired in 2021, and she took full responsibility of the practice.
And what are your participations in Avanti Derma right now? Are you, besides, I've seen you in follow boards, you answer patients, you were showing me the emails, you always check the emails that Ian gets, and you also respond. What's your participation right now?
Yeah, I'm in a very comfortable situation at this moment. It was hard. I think I earned it because it was almost 40 years of practice. So what I do now is when I get my first coffee in the morning, I go to the computer and see what's going on with new requests, see what's going on with patients that are coming or patients that were done like the day before, and I check their evolution, and I'm looking at everything that is happening in the office, and I let things go as long as they are under control. When things are under control, then I jump in and suggest to do this, that, whatever is needed, right? I monitor, because I like it, I monitor followers and other media related to Avantiderma. And sometimes I enter, I always sign, like when I post on follow boards, I always sign at the end Dr. C at Avantiderma, so they know that it's me that personally who responded to that thread or something, right? And everything. So I look, is the beauty of the cyber world now. I most of the time live in Puerto Vallarta, Mexico, but I'm there 2 hours in advance. So by the time I had breakfast, went to the gym, and took a shower and everything, I'm ready. It's 9 o'clock in Tijuana. For me, it's 11 o'clock. And the office opens, and I'm ready there, checking what's going on.
So you're basically you continue to be the administrator of your clinic. You administrate everything. You come here to Tijuana and Puerto Vallarta from your laptop, and you're still the consultant, the main consultant.
Yes. And I participate in follow boards not only as a member but also as a consultant if they want.
Right.
I try not to impose my comments on every thread, but I try to be there if they need me. And administration, but from the point of from the medical point of view. Obviously, Avanti has its own administrator for all the administration, right? And I stand on the medical side of I call myself medical director of Avantiderma.
Right. And what about Ian? Who's Ian? Because a lot of people ask for Ian all the time.
Ian is becoming the popular person in Avantiderma, which is great. Ian is a great guy. Ian is our patient coordinator, and actually he took the place of a girl that we had there before, and he is so efficient that he kept the patient coordinator position plus the medical assistant coordinator. So he works with his role is to get the first email of the patient, and from there do the recruiting process and bring the patient to the office, coordinate shuttles and arrivals and departures and all that, stays here in the hotel that we have in the same building complex, and then bring the patient to the office, and then help Dr. Morales with each patient. So it's a multi-faceted, multi-purpose,
Yes.
high qualified guy, and he's a great element.
So he is not only the guy that answers the emails and the information, but he's also the guy that's in the procedure live with you.
Yeah, we have other members of the team that can assist. Like sometimes when we have an excess of patients, there's always a girl, somebody else can help. But he is the one that helps Dr. Morales in almost 100% of the patients.
During the procedure and also afterwards, the recovery.
He does the post care he trains the patient on how to do his post care, and then he monitors. Sometimes patients, we kindly ask, by the way, patients not to call them in the middle of the night if it is not needed, but if it's needed, by all means, they can call. Ian has a dedicated phone line to Avantiderma. So if they call at 10 p.m. or 2 a.m. in the morning, he will come and see what's going on and help the patient. Of course, we kindly ask the patients not to do it if it's not necessary.
Right, yes. So if for people watching, and if there's a guy right now that, let's say he just wants to make his penis bigger right now. He's never done it before, it's his first time, he's only been checking things online. What he can do? What is the first process that he could do? First, check your penis. First, know how many cc's do you have to put in your penis. First, check what result you want. What are the first thing that he should do right now? This guy that is on his computer, he wants his penis to be bigger.
Well, typically the typical scenario is the patient finds us on somewhere on the internet, and then he contacts us. We respond with our e-brochure. It's an electronic brochure that has the basic information of non-surgical phalloplasty and the services that we provide. So once they get the e-brochure, which covers basically our intention is to cover 100% of the doubts of that somebody can have. But of course, there's always questions. Every patient has extra questions. So they have two options. They can continue communicating by email, or they can establish a Zoom conference call. That I encourage that because that's the way we can convey more information in a conversation, right? Mm-hmm. And once they accept or they want to be a patient, a prospective patient, then everything is there, everything is in the brochure. Then we collect a security deposit to secure their appointment, and then they start working with Ian with the flights, the hotel stays, the rest of the payments and all that. As for what are we going to do with the patient, I highly encourage patients not to push for X amount of filler. I tell the patients, let us decide, because even, first of all, they are remote. They're New York and they want to know how many cc's we're going to use. First, we're not seeing your penis, or if we see it, it's in a video clip.
Right.
So, and even when they come to the office and we see them personally, and it's different than when we have them in the surgical bed. At that moment is when we know exactly how many cc's.
Even if they do the measurement thing, that they put this thing to measure your circumference of the penis and they send the video, even that's not enough.
It's not enough. Even touching them, even exploring them here in the office. Sometimes once you're injecting, you're like, oh my God, this guy's going to take way more than what I thought, or less than what I thought, right? We had an engineer, because this is not mathematical. This is a human body, right?
Yes.
One day we had an engineer, and his request was like if I was to get a cylinder of steel and put him in one of those rotary machines, and he wanted 1 millimeter there and 2 millimeters here, and I said, it's not the way it works, right? You're gonna gain between half inch to 3/4 of an inch, some in between. We can predict to some extent. So that's something that we sometimes we have patients that they go like, I want 20 cc's, but you see them and they are 4 inches in length. So 20 cc's in reality, you go like, where do you want me to put them, right? Or the opposite. We have sometimes patients that are overly large in every sense, length and circumference, and 20 cc's is nothing for a patient like that.
20 cc's.
Yeah. So it all depends. It all depends on the individual.
If is there something that they have to do before coming here? Like, okay, so let's say I'm from Canada. Checked you out, checked the brochure, made my appointment. I'll see you in 2 weeks. What is he supposed to be doing in those 2 weeks? Not having sex, not having this food, what?
Nothing specific.
Nothing.
No. Sometimes we get all kinds of patients. Sometimes we get patients that are in, let's say, blood thinners. And in that case, we're like, you need to see your doctor, and you need to take advice from your doctor, from your cardiologist or whoever, because we need you out of, let's say, Coumadin whatever they're taking as a blood thinner. Because the moment we start poking the penis, he's going to bleed all over the place. So we were like, okay, see your doctor, tell him if you can stop under his responsibility, if you can stop the medication, like 1 week before you come here. And sometimes we have diabetic patients that they get infections, EC, they have other issues, and sometimes we have patients with priapism, with different things. I can go, the list is long. So in those cases, when patients have a primary care physician, we need the physician to say, okay, it's good for you to go. Because we're not here to change any medications that they're taking or anything like that. This is an elective procedure, and it has to be done when everything aligns.
And how do you know that everything aligns? Do you ask them beforehand, before they make the appointment?
Yeah, there's a online consultation form, because there are other things. Like one day, this online consultation form was created after we had not a good experience. We had this patient coming from, I'm not going to say countries or anything like that, but this patient came from far away, from basically the other side of the world, with his father. He was the only kid, and it was a family drama to the point that the guy being 20-something, the father came to make sure that everything was okay. And so we said, okay, that's fine, we'll do it, and blah, blah, blah. And it was a micropenis.
Oh.
So they came from the other side of the world, and when I see that thing, it was way less than 3 inches in erection. But like, I'm not gonna be able to do anything here. And they're coming from that country.
Right. Yes.
And I'm gonna tell them no. Can you imagine? So that form came out of after that patient. When we have the patient assess himself.
Yes.
So, and we say, one of the points that they need to tell us is, I do not have a micropenis, right? I do not have a malformation in my penis. I don't have surgeries. I don't have previous procedures, especially when they get injected things like silicone or something like that. So once they clear all that, they're safer. It's safer that they come. And if they lie, if they tell me I don't have a micropenis and they come and they have a micropenis, well, it's not my responsibility.
Right.
Okay.
Yes.
Yeah.
And what about the uncircumcised circumcision and not uncircumcised?
Yeah, circumcision. There are 3 groups of patients: ideal patients, less than ideal, and patients that we won't take. The uncircumcised patient enters in the group of less than ideal patients, which means less than ideal is, let's talk first, specifically. Let's have a conversation. Let me explain what is going to happen to you. Let me tell you that you're not going to get a lot of volume. Let me tell you that the results are going to be probably what you expect. And then come. Oh, let me tell you that eventually you might need a circumcision. So if you will not get a circumcision, then I cannot work on you. Because the deformities with fillers in the uncircumcised patients are very common. And sometimes we need to do circumcision, or the surgeon needs to do circumcision to correct the malformations that created by the filler. So if a patient says, no, I don't want to lose my foreskin under any circumstance, then I go, no. Then we can use a little bit of hyaluronic acid. If things go wrong, we dissolve it, and that's it.
So basically, if you are uncircumcised, you can still come, you can still have elans, you can have the temporary, semi-temporary, long-lasting, semi-long-lasting. No, how will you say
basically permanent, long-lasting, and temporary.
Long-lasting, and so basically, if you are uncircumcised, you can still come. It's just a matter of be aware that there's not a lot of there's a limit of how much you can get in because you have that extra skin. And if you like the results, then you're fine. But if you want more, there's going to be a point in time where you have to get the circumcision in order to inject more product.
Right.
And it doesn't matter if you want to inject the PMMA, temporary, long-lasting, or HA. You still have to do the circumcision if you already have product and you want even more.
Right.
Correct?
Yeah.
There's no...
Yeah, it's the moderation is the name of the game in the uncircumcised patient. And moderation means also moderate gains. And some patients don't want moderate.
Yes. But you have a lot of patients that are circumcised, right? And their results look great because I saw a couple of pictures. We cannot show the pictures right now, but the results look as a circumcised patient.
Right.
I mean,
and we have patients that have gone through circumcision to correct imperfections.
Right, afterwards, right?
After, yeah. But they're okay. We tell them in advance, you're risking this. You want to go ahead? And then we go ahead.
But you can have a pretty decent, great result if you are uncircumcised. And yes, just a matter of how much afterwards.
Well, I would say, like, I encourage no more than 1 inch for the circumcised individual. No more than 1 inch. I recommend no more than ½ inch. Let me rephrase. I'm not sure if I said the correct thing. No more than 1 inch in the circumcised individual.
Okay.
No more than ½ inch in the uncircumcised.
Yes, I think you said it.
Okay.
Yeah, I think you said it. Yes. Very good. And so, thank you very much, Dr. Casavantes. We hope to have the second time for interview with you. Yes.
I think for what I see at the moment, I think we should do something specifically directed to enhance the long-lasting product, because what I've seen the last couple of years is the interest and the preference for Lance is growing. So it's something that is in the mind of many patients. So I think they deserve to be informed about what is Lance and what is the difference between PMMA or HA with Lance and all that. The whole thing is enough to have a podcast about it.
Okay, very good.
Thank you so much.
Thank you. Bye bye. See you.